Hello everybody, welcome to my YouTube channel Nurse Ed Simplified. Myself, Katrina Dinesh Kumar, I'm an RN CIC CPHQ certified and I'm here to help my GNM, B.Sc, post-basic and my MSc students to some topics that are quite familiar to them and which are quite frequently asked in their examinations. So after a little bit of research and after a little bit of work and homework, I have managed to find some topics and discuss them. As the videos go by, you are free to put your topics into my comment box so that we can have them discussed. Okay, so let's move on to our first topic, that is myocardial infarction. Okay, so what do you mean by a myocardial infarction? As you can see in the picture itself, that you can see a gentleman, he's holding his heart and he's in pain. This is typically how a patient will present to you when he is in myocardial infarction. What is a myocardial infarction? A myocardial infarction is a condition in which the myocardial tissue of the heart is deprived. What do you mean by deprived? By deprived, we mean that is not supplied or there is no sufficient, adequate supply of oxygen because of the reduced coronary blood flow. There is profound imbalance between the myocardial oxygen supply and demand. So the oxygen supply is less, but the demand is quite high. So your myocardium is deficient and there is a damage happening in the myocardium. So when they ask you about definition of anything, not only myocardial infarction, in your examinations, when they ask you about a definition, what they want to know are some keywords. You can write a history on definition, but they will give you marks only if you have the keyword. So what is the correct definition? It is myocardial infarction is a disease condition caused by ischemia. What do you mean by ischemia? Ischemia is lack or deprivation of oxygen supply to a part of the heart, resulting in death of the myocardial cells. As you can see in the image, the blood flow through the coronary artery was great, and when there are plaques formed, it becomes reduced and there is ischemia in the myocardium. The incidence, if you talk about India, we see that men from 29 to 69 years average around 64 out of 1,000 people suffer from myocardial infarction. And unfortunately, the death is around 32% due to myocardial infarction. If you can see the table, you will see that this women suffer less than men, or rather to be more specific, men have more prevalence than women. So from 45 to 54, you see men are ranging more than women, around 1.14%, and so on. What are the risk factors? Now, when they ask you about etiology of MI and when they ask you about the risk factors of MI, they are the same. You have to write or divide them into two. One is non-modifiable and one is modifiable. Why we call it non-modifiable? We call them non-modifiable. Why? Because these are things that you cannot change. It's already inbuilt in your genes. It's already inbuilt in you. You cannot change them. Like your age. The risk of developing a myocardial infarction with age increases. That is, every 10 years, it will double. This is a risk. Sometimes you might have even MI coming to an individual before 55 years. Sometimes even after 55 years, 60 years, the patient has never had an MI. So this is just an incidence that they are seeing. Gender, as we saw in the previous discussion, it's more in men, unfortunately. Race, we see that the African Americans are more likely than Asian adults. What do we mean by that? Is that African Americans, because of their diet and already in their racial characteristic, they are more likely for cardiological or cardiac issues than Asian adults. And among Asian adults, we have Indians, Philippines. We are the countries we are ranging a bit on the higher side. Family history, and if you have a strong family history, that is something you cannot change. If you have someone who's had an MI and has had a death because of the MI, you are more at a risk of developing. What are the modifiable risk factors? These are called modifiable because they can be altered with your behavioral changes. For example, cigarette smoking. How cigarette smoking causes a risk? It's because it increases your blood carbon monoxide levels. So they increase the risk for cardiac diseases as a whole, not only MI, but any cardiac disease like ACS or anything. Elevated blood pressure. Why? Because it increases the ability of your ventricles, the pressure of your ventricles to pump. So the someone who does not have a high blood pressure, the heart's ventricle will be pumping with a normal pressure. But someone who has an elevated blood pressure, they will be pumping it at a higher pressure. Next is hyperlipidemia, that is increased cholesterol level, because they are one of the leading factors for myocardial infarction. They increase the platelet aggregation, that is accumulation of the platelets, and that leads to thrombus formation. We will discuss it in the pathophysiology. Diabetes, high blood sugar, they always make your vessels damaged and your nerves, so they decrease your heart's ability to pump. Physical inactivity, when you're physically inactive, your lipid cannot be metabolized properly. The lipids that you're taking through the food, it cannot be metabolized properly, and they increase your risk for thrombus formation. Obesity, same thing. When you're obese, it's because of your sedentary lifestyle. So when you are a sedentary lifestyle individual, your lipids are not properly metabolized, and abnormal lipids, they accumulate. They are what are abnormal lipids? They are the LDL, low density lipoprotein. So they lead to increased risk of MI. And stress has also been accumulated as, or has been found out to be one of the reasons also. So as you can see in the picture, we have some non-modifiable, that is it's already in your genes, your age, your gender, and some modifiable, that is smoking, high blood pressure, high blood cholesterol, physical inactivity, and diabetes. Next is the blood supply to the heart. Before we go into details of what happens where, let's go through the main arteries or to the main veins. So our blood supply to the heart, we have the main arteries, like your aorta, we have the pulmonary trunk, we have the left atrium, right atrium. One of the main veins are your superior vena cava. Okay, so now what I want you to see is on the right side of the figure, the main four arteries that are responsible, that if they get blocked, are responsible for MI. Your left main artery, your circumflex artery, LAD. Commonly you will see in the file, if you go to the clinical areas and if you open a file of a patient with MI, you will see 100% occlusion LAD. What is LAD? But it is left anterior descending artery. Okay, or say 60% occlusion to RCA. What is RCA? A right coronary artery. So these four arteries you must have in your mind. So when the doctor tells you that this patient has a 45% occlusion in the LMC, you must immediately click yes, it's a left main coronary artery. Okay, now we come to the pathophysiology. Why we are stressing on the pathophysiology is you must know this, that you can see here. Why we have shown you something like this is for you to understand. You can see this area. This is the lumen of your artery. Artery looks, it's like a tube, it's like a pipe. So this is your lumen. This is your normal heart artery, lumen. Now, when there is a fatty streak intracellular lipid accumulation, your lipids are accumulating here, right? See, you can see them. Now, they are continuously accumulating now. They are increasing. Extracellular, now they have developed a core here. Now, the unfortunate part is, or the most climax of the movie or of the scene or of the condition is when these fibrotic plaques are developed. And the worst is, unfortunate part is when they rupture. These plaques rupture and they create the MI. Now let us take it very easily in the pathophysiology. So as we said already that we have this cholesterol deposition. Okay. This cholesterol deposition, it gradually forms a plaque. This part is very important. It forms a plaque. This plaque, what happens is they may rupture, and this leads to activation of clotting mechanisms. That is leading to platelet aggregation and fibrin deposition. This leads to the thrombus formation. They form the occlusive thrombus in the coronary artery, in any one of them, like your left main coronary artery or your RCA or your LAD or your circumflex, anyone. And this thrombus blocks, mind it, this word is very important, blocks the coronary artery and obstructs the coronary blood flow. It means your oxygenated blood is not going to the myocardium. And when this takes some time inside, it's happening for some time inside the heart, myocardium, there is irreversible change. What do you mean by irreversible? That it cannot come back. It cannot be normal again. And the myocytes or the myocardial cells, they become dead. They die. Okay. So this is a pathophysiology very shortly. Atherosclerosis, they build up the plaque in the coronary artery. The plaque, it ruptures. It must rupture for the MI to happen. Ischemia is when they rupture and there is decreased oxygen supply to the myocardium, and the myocardial cells, that is your myocytes, they are dead. There is irreversible injury. Now we would stress on what is the classification. How do you classify MI? Okay. According to, number one is according to the anatomic site, which area involved. That is your anterior, posterior, lateral. You will see in your file that they are telling you it is anterior MI, it is posterior MI, it is lateral MI, septal MI. Okay. Now circumferential, or it can be a combination. You will hear it is anteroseptal, anterolateral, posterolateral. Okay. Now next is according to the degree of the thickness of ventricular wall involved. How much of the ventricular wall is involved? How much? It can be full thickness, it means the whole of the wall has been involved, or it can be subendocardial, laminar. According to age, if you see an ECG, you will see the doctor will, you will listen, you will now go to your clinical areas and you will observe your physicians telling you, this is a recent one. Yeah, this is an old one. Okay, so which means there are two types. One is newly formed and one is advanced. When you talk about newly formed, they are acute, they are fresh, they are recent ones. Advanced means that they had been an MI before and that has sustained, or it was treated, but you will still see changes in the ECG for some time. Old, healed, so they are divided into old, healed, organized. Clinical manifestations. Whenever you write clinical manifestations, always remember to write them system wise. Never write them 1, 2, 3, 4, 5, 6, 7 till 20. You may write till 20. But someone who wrote system wise, they will get more marks, or the examiner will be more happy to see their paper rather than seeing 1, 2, 3, 4, 5, 6, 7. Okay. So always break your symptoms into systems. So first we begin with pain. How will the patient present to you? He will present to you with severe pain. That's how he will come to you, with nothing else but pain. What is the cause of the pain? The chest pain is due to lack of the oxygenated blood supply to the myocardium. Location, you will see he'll be holding his chest most of the time. So it will be substernal, retrosternal, or epigastric. So whenever you write about pain in a viva or in any question, anytime related to healthcare, if they ask you, how do you, see pain, or how do you identify the pain, or what is the pain of an individual with MI or with whatever condition, appendicitis or cholelithiasis, what will you say? It will always be divided in PQRST. That is provocation, quality, radiation, severity, and time and duration. So this, when you talk about PQRST, they are very happy. They know that you have been able to take proper history from the patient. So you will ask the patient, what is your provocation? What were you doing? I was stressed. Or he will say that I was working in deep, it was very hot and humid outside. I was working there, suddenly I developed. So there has to be some stressor. Quality, it must, how do you describe the pain? How will you ask? You cannot ask the patient, tell me the quality of your pain. You have to ask him in a language he understands. So you will be asking him, tell me or describe to me the pain. So he will tell you, sister, it's like a pressure, it's like I'm feeling tight, or there's a burning sensation, or you will say, I feel there's something heavy on my chest. Next, you will ask him the radiation. Do you feel that your pain is radiating somewhere or it's referring somewhere? You call it radiated pain or referred pain. So it may radiate to the neck, jaw, arm, or back. Next, you will come to the severity. How severe is it? You have a rating scale, numerical. You have many scales to measure the severity. So one among them is a numerical pain scale for a patient who is conscious. You will ask him from 1 to 10, if from 0 to 10, if 0 is the least pain and 10 is the worst pain, how would you rank? He will tell you maybe 8 or 9. It's that bad. And it is not being relieved with pain relievers. What is the time or duration? You will see the patient will tell you just from 15 minutes, sister, or just 20 minutes. I was just fine. Suddenly I started having, and so on. Cardiovascular, what is the reason? It is ischemia. Location, as we discussed, substernal, retrosternal, or epigastric. Signs and symptoms. Whenever you write the clinical manifestations, try to make it in signs and symptoms. Why? Because the examiner will know that you have asked objective data as well as subjective data. Signs are your objective data. Symptoms are your subjective data. So signs are that which you see in the patient, that is your vital signs, and symptoms are something that the patient will tell you. So signs will be in cardiovascular, you will see the blood pressure and heart rate will be elevated initially, but gradually the BP will fall down because of low cardiac output. Symptoms are, he will tell you, sister, I'm feeling like my heart is racing very fast. I feel chest pain. I feel my head is light. I cannot concentrate. I'm feeling dizzy. Next is respiratory. Why this respiratory pain happens? Because, or this respiratory symptoms develop, is because your damaged heart muscle, it is limiting the pumping action of your left ventricle, which is affecting your left-sided heart failure and thereby your lung congestion. So what will you see? You will see signs of pulmonary edema in the patient, like crackles on chest auscultation due to fluid overload. What are your symptoms? What will the patient tell you? Sister, I cannot breathe. I'm breathing too fast. Dyspnea, tachypnea. Genitourinary. What are the genitourinary causes? Because of low cardiac output, there is low renal perfusion. There is low supply of oxygenated blood to your kidneys, which are not enough to maintain your GFR. What is your GFR? It is a glomerular filtration rate. So what will you see in a patient? You might see poor edema due to poor contractility, and you will see crackles on the chest auscultation. What are the symptoms? The patient will tell you that I'm feeling I did not pass enough urine. So oliguria, and when you will measure, you will see it is less than 30 ml per hour or 400 ml per day. And patient is diphoretic. Next is gastrointestinal. This is a very common sign you will see among patients with MI. They will complain of nausea and vomiting, and they will vomit. They will vomit. Why? Because your ischemic cardiomyocytes, that is your cardiac heart muscle, they release something called lactic acid. They increase your creatinine in your body and the metabolites. So this stimulates the autonomic nervous system or your peripheral receptors of the infarcted region, and this leads to nausea vomiting. And nausea vomiting related to MI is termed as cardiogenic nausea vomiting. What are the signs and symptoms? That is, you will see nausea, vomiting, epigastric pain in the patient. Integumentary, that is your skin. What symptoms or signs do they produce are, why does it happen? Because the pumping of the blood, it happening to the clogged arteries, that is your blocked arteries. So that is leading your heart to put more effort. It's trying its best, sir. Our heart has been, or our body has been so beautifully created that whenever there's an issue, it's fighting to settle it down within itself. So your heart is working hard. and that leads to activation of the sympathetic nervous system, and that leads to catecholamine release, and then you start having severe sweating, that is diaphoresis. So what are the signs you will see if you cool and clammy skin? This word is very important because this is typical in a patient with MI. Cool and clammy skin, pallor, cyanotic, and diaphoretic. Neurogenic. What neuroscience will your patients display and why? Because he's having low perfusion to our brain, cerebral hyperperfusion, and that causes your signs, that is your altered level of consciousness. He cannot do much of his motor functions properly, and sometimes there is altered speech. Symptoms what the patient will tell you is lightheadedness, dizziness, headache, and visual disturbances. Psychosocial. We cannot avoid this clinical manifestation now. It is newly added to the list of clinical manifestations recently. Why? Because they too affect our activation of the sympathetic nervous system. Because when you have pain in your heart, be it due to any reason, it may not be MI, you get panicked. So that panic and that anxiety is activating a sympathetic nervous system, and that is because your patient will come to you like, he's so stressed and apprehensive of the pain. We move on to the diagnostic evaluation. What are the tests done to confirm that it's an MI or a myocardial infarction? First, we must not, the clinical assessment is done. That is, you assess the patient, the clinical history, the PQRST that we did for the chest pain. He comes to you with chest pain, you do the PQRST. That itself will identify around 50 to 60% of the case. Next, we ask him his family history. We ask him his medical history. We ask him his surgical history, whether he's had a CABG or any cardiac history before, any cardiac surgery before. That will also give you an idea. After that, this should not take you more than 5 to 6 minutes. We next move on to the most critical part, that is your ECG. You must immediately take an ECG for the patient without wasting much time. What we do in emergency settings is, while we are putting the ECG leads on, we take the history as well so that we don't miss the critical time. We do the ECG. We may do an echocardiography and CT MRI depending on the criticality. With an ECG, what we send immediately is a serum cardiac enzymes. We will discuss it in details. Stress test and X-ray, they are done also, but not as an immediate diagnostic test. So the immediate is your clinical history, your PQRST, ECG, echo, and your serum cardiac enzymes. X-ray will show you what? X-ray will show you cardiomegaly. That is, your heart has been trying to pump for a long time, so it has become dilated, a left ventricular hypertrophy, and your cardiomegaly. Next, we come to what is an invasive. After an ECG, what they might directly take you to a cardiac catheterization unit, and they will do a coronary angiography to find out how much or what percent or which artery is blocked. So immediately, as I told you, we do not waste time. We do a ECG, we send the cardiac biomarkers, we may do an X-ray, we will do an echo, a coronary angiography, and a stress test. Now we'll come to each one of it in detail. In ECG, that is electrocardiogram, what is that? It provides you the basic information of diagnosing acute MI. Acute. Now the classic changes are, as you can see from here, this is your ST elevation. What they want to see, what is ST? You can see in this picture, right? P, Q, R, S complex, and this is your T. So this distance between S and T is the ST segment, and this is your area where we'll be looking into. This should be the same as the isoelectric line. But when it comes to an MI, this becomes elevated. When it may be depressed down the isoelectric line, and the T wave, which should be upwardly placed, it becomes inverted. So what are the ECG changes? You will see an ST segment elevation. You may see an ST segment depression, T wave inversion, presence of abnormal Q wave. What is an echocardiogram? We proceed to do an echocardiogram. This is to know how well your and ventricular function is taking place, how well it is being able to eject or pump the blood. So a normal ejection fraction is 50 to 70%. We call reduced ejection fraction from 41 to 49, 41 to 49%. This is very important. That is a cardiac markers. You will see a doctor telling you, send your serial cardiac markers. So at that time, you must know what are the serial cardiac markers. What are they? First and foremost is your troponin. Okay. So when you have a troponin, you will see that the normal range is 0.04, less than 0.04 ng per ml. Anything more than that will be something of concern to you. Generally, they are at a when it is just new MI, it will be 4 to 6 hours duration. You will see there will be an increase. When it will reach the peak, when it is 24 to 48 hours, and it will stay in your blood for 10 to 14 days. Similarly, your CKMB, myoglobin, LDH, and proBNP. Nowadays, pro-BNP, we do pro-BNP even for non-cardiac cases to see the extent of level of damage. Okay. Next is your angiography. It is to detect the abnormalities in the blood vessels. That is whether it is stenosed or occluded. Is it stenosed? Means is it become thin because of the plaque, or is it occluded itself? Occluded means totally blocked. You will see in the results. It like angiography done and it has been found LAD or 100% occlusion. So you must understand that that particular plaque has completely blocked or occluded the LAD, that is a left anterior descending artery. Hmm? So how do you do the procedure? How you must have an idea. So what do we do is we inject a contrast agent or a dye into the blood vessel, and that dye is able to pick up the blockage. So whichever area the dye did not pass, that area is the blockage, and we see it through an X-ray or imaging. Next, we move on to how we manage a patient with myocardial infarction. Always remember, your time is heart. Time is heart. You cannot afford to lose the time for the patient or the door to balloon. That is the time the patient came and when did you do your procedure. That is your PTCA, okay, or your CABG, whatever. That is a door to balloon, the golden period. Medical management. How do you medically manage? When we talk about medical manage, we are mainly talking about the drugs used. So the drugs used are commonly antiplatelet drugs. We'll discuss about them. The analgesics, the nitrates, beta adrenergic blockers, CCBs, your calcium channel blockers, anticoagulation therapy, fibrinolytic therapy. When we talk about surgical management, we are meaning basically two that is commonly done, that is your PTCA, percutaneous transluminal coronary angioplasty, and your CABG, that is your coronary artery bypass graft. And we also do a procedure called atherectomy. Next, we come to how are we going to nursing manage the patient. We will assess the A, B, C, D of the patient. That is your airway, breathing, circulation, and disability or the need for defibrillation. We will give oxygen, though nowadays, before it was that you must give oxygen to a patient with MI, but now the standard goal is if the saturation is less than 94% on room air, we will give, otherwise we will not. But we do keep it as a part of the management. Insertion of large bore IV cannula, preferably in the antecubital. Preferably, but do not waste time to multiple pricks. If you cannot locate, go down to your preferable site. Encourage bed rest, check for peripheral pulses for the rhythm and the rate, and monitor vital signs. Medically, how you manage. What is my goal? My medical management goal is to restore the coronary perfusion, to relieve pain, of course, and to make the patient prepare for cardiac rehabilitation. So we give them three. If I divide them, we have three medicines which we give as a part of our antihypertensive management. That is your vasodilators, your beta blockers, and your calcium channel blockers. Vasodilators, we give anything that is nitrate. Why? Because they help in dilatation of the blood vessel. Beta blockers we give. Why? Because they decrease the workload on your heart muscles, so your myocardial oxygen demand is less. Examples are your propranolol, labetalol. You will hear these terms. So next time you hear the term like this in your clinical area, quickly go check the file of the patient. Calcium channel blockers, they improve the coronary blood flow. Examples are nifedipine, verapamil. Next group is something called anticoagulant drugs. They reduce the they do not allow the thrombus to be formed again to what is already formed. That is your heparin. You will hear the physician, ED physician telling, give heparin loading dose. So if you hear like this, please go and see what is the loading dose like. Opiate analgesics, we will give something to reduce the pain. So this will be mostly our drug of choice is morphine sulfate. The doctor will tell you give 10 mg morphine IV. Next and the most important is the thrombolytic drugs. So they act or they work by lysing or removing or breaking down the infarcted artery thrombus or clot. Like you will hear the word SPK, streptokinase or urokinase. This is a quick chart of what you will do immediately when the patient comes to you. He says he has chest pain. Sister, I cannot breathe. I have chest pain. Immediately put him on the bed. Take his vital signs. And when you're doing his vital signs and his ECG, let someone take an ECG quick history of the patient. That is what we did as a PQRST and the initial history, whether he's diabetic, hypertensive, or whether he has any family history, whether he has any surgical history, or did he take any medications, or what was his stress factor, and so on. As soon as it is identified as ST elevation, MI, what you will do is you will give morphine, as I told you, 5 to 10 mg IV, along with antiemetics. You will give oxygen only if it is less than 94%. Aspirin and ticagrelor loading dose. We call it loading dose. That is 300 mg and 180 mg. If it is less than 12 hours onset, we will see if we can do a PCI. What do you mean by PCI? We mean percutaneous intervention. So when we do a PCI, it will be delivered within 120 minutes of the time. 120 minutes means within 2 hours of the time of fibrinolysis. But because of the condition of the patient, we cannot do PCI. We will go for fibrinolysis or antithrombin. If we can proceed, we will go with primary PCI. Is it okay? Okay. Next, what it is? Next, we come to know if it is more than 12 hours. What do you do? Like the patient came to you for more than 12 hours, that it has happened yesterday. In that case, you will continue, you will see how the ischemia has progressed. You will not discharge the patient. You will see the progress. You will do serial trop markers, cardiac markers. You will do serial ECG. If the patient is for PCI, you will take him with for coronary angiography. If not, give him the supportive loading dose and do the cardiology assessment. Okay, so any sort of PCI, it must be initially assessed. When you will go to your own setting, clinical setting, every organization has their own clinical setting, but the goal is the same. Surgical management, what is PTCA? It is angioplasty or stent. We place a stent in the percutaneous coronary intervention, where we are putting a stent into the narrowed or the blocked section of the artery. So what we are trying to do, we are trying to restore the blood flow. Okay. Next we come to CABG. That is, as the name suggests itself, it is coronary artery bypass surgery or grafting. What we do is it is a surgical procedure where the coronary in treatment of coronary artery disease. What we are basically trying to do that it diverts your blood around a narrowed or clogged part to improve the blood flow. Mostly, which is your artery, the most preferred artery is your saphenous vein of your leg, or they might have other options as well. You might have the radial artery, like you will hear in the procedure, CABG done, radial approach, so on. Okay. Next, we come for another procedure, though it is now coming into awareness now, that is the atherectomy. It is that it opens the arteries blocked by the plaque. What we are doing is there's a sharp blade or a laser or a rotating device or like a scraper, which will dissolve or break the plaque without making any incision or anything. It is usually a minimally invasive procedure of removing the atherosclerosis. Now we come to the most favorite part, that is a nursing diagnosis. What will you put as one, two, three? This nursing diagnosis is very important for your marks. Why? Because as you prioritize the nursing diagnosis, which comes first and which comes last, that decides how well you do. So the first obvious diagnosis is acute pain. Related to, you can write acute chest pain, whichever. Related to myocardial ischemia resulting from coronary artery occlusion. Ineffective tissue perfusion related to thrombus in the coronary artery. Dysrhythmias, that is abnormal rhythm related to electrical instability or irritability, secondary to infarcted tissue. There is impaired gas exchange. As you can see, there is not good gas exchange related to ineffective breathing pattern and decreased systemic tissue perfusion. Activity intolerance, because of your myocardial oxygen demand is more, so you're fatigued, resulting from increased myocardial oxygen demand. Ineffective coping related to your effects of acute illness and major lifestyle changes, like you've been a chain smoker, you've been an alcoholic, and now you've had to make those major changes. So they are related to your coping mechanisms. And last but never the least, always add anxiety. Any disease condition will have an anxiety for you or for the patient. So always write anxiety as one of the points. Anxiety related to the possible lifestyle modifications or your fear of occupational insecurity and anticipated financial burden. Next, we come to the complications. What are the complications are divided into three: the arrhythmias, mechanical complications, inflammatory complications. Under arrhythmias, we will see heart blocks, cardiogenic shock, heart failure, embolism. Under mechanical, you will see severe mitral regurgitation, cardiac tamponade, as you can see in the picture. There is right-sided heart failure, and there is aneurysm. That is a blood vessel itself. The wall of the blood vessel has become very thin or very fragile, so that leads to an aneurysm. What do you mean by an inflammatory? What comes under inflammatory complications? Number one is very obvious, is your Dressler syndrome. It is like pericarditis, but it is a second. It is accompanying MI. So when you talk about syndrome, you must know that there has been a history of MI for the patient. Okay, because of the injury to the pericardium, he will present to you with almost the same symptoms as pericarditis, like with fever, pleuritic pain, pericardial effusion, and so on. So what it is basically inflammation of the sac surrounding your heart, similar to pericarditis, but mostly with your MI. So pericarditis and post-myocardial infarction. Next, we come to cardiac rehabilitation. This I have seen only once asked. I have not seen it too much in your question papers, but maybe a couple of times, not more than that. But for my post-basic students, I have seen for more than 2 times. So what are these? They are like, it is divided into 4 phases: phase 1, phase 2, phase 3, phase 4. From the, as you can see in the picture, that from the time the patient arrives with chest pain. So now he's in your hospital in phase 1. What we are doing, we are helping him, regain the mobility, education, personalized assistance, psychological support. What do we do in phase 2? This is also in hospital. We do again physical examination. We assess any residual cardiovascular risk, like his sugar is still high or his BP is still high, his DLD is high. Physical performance testing, training program definition. We explain all this to the patient. Phase 3 is at home, and phase 4 also. Phase 3, what we are trying to do is exercise training. We give them aerobic, you must do walking, swimming this much time or this much days in a week, and so on. We give some lifestyle modification, which is very important. That is your diet. You should have low saturated fat, reduced sodium, high fiber diet. This question is very important, that if in Viva, sorry, I'm so sorry. They may ask you in Viva that what is one of the most important health education that you would give to a patient with MI. Please don't forget to mention heart healthy diet. What do you mean by heart healthy diet? It means low saturated fat, reduced sodium or low sodium, high fiber diet. Then we come to weight management, smoking cessation, alcohol moderation. Fourth phase has how well you are being able to maintain them. That is how well you are able to keep yourself, maintain the cardiovascular health. That is the phase 4 about. They revolve around the same thing: heart healthy diet, weight management, smoking cessation. They talk about physical activity. Do not be inactive, try to be more active, and adherence to your medication, pharmacology. Now, prevention is always better than cure. So, if anytime they ask that you see a patient who's at risk for MI, what are the few areas that you would cover for your prevention? Myocardial infarction. Number one is stop smoking. You must tell him to bring down his smoking. It's very easy to say to stop, but it takes them time to go through it. It will take time, but we will give him that time, but it must be gradual and it must come down. Next is choosing good nutrition, that is a heart healthy diet, being physically active, aiming for a healthy weight according to your BMI, managing diabetes, your blood sugar should be under control, reducing stressors around you. It can be work, it can be family, whichever be. Go for short breaks between your work. Uh, be close to nature. Try to enjoy every moment with your children, and so on. Limit alcohol consumption. Make sure you get enough sleep, that is 6 to 8 hours of sleep, and aiming to lower the blood pressure or keep it within acceptable range. This is my assignment for each one of you. This is the nursing care plan format, and this shows assessment, nursing diagnosis, goals, therapeutic nursing intervention, rationale, and evaluation. This is now how it has been divided, or this is what we expect. So you will formulate a nursing plan for a 44-year-old patient with myocardial infarction who's admitted. He was admitted in the ED and now he's come to you in the CCU for CABG. That is for the procedure. So you can formulate this and you can either give it to me or you can discuss, whichever, in my email ID. I'm very happy to receive it and help you. And second question is enlist the signs and symptoms of a patient with an angina pectoris. So what I'm looking for is the subjective data and the objective data and the clinical manifestations of a patient with angina pectoris. Why? Because this has come as a 5 marks question to you. So let's see how well you write. You can mail to me in the email ID or you can comment that you have done or you have discussed or whatever. It's up to you. Thank you so much. If you have any questions or any doubts, please do not forget to comment. And you have any topics that you want me to discuss, I'm most happy to do that. You can put it in the comment box. We will see to it. Thank you. I hope you enjoyed. And we have few more videos coming up on one of the most important emergency managements in the ED, and that is on ESI, or Emergency Severity Index, which has come 3 times for B.Sc students and around 2 times or more for MSc, for my MSc students, and also asked during Viva to a group of students. So we will talk about it in the next video. Till then, bye bye. See you. Have a happy weekend.